Good afternoon. Today's topic is going to be about cirrhosis. Yay, cirrhosis. It's my favorite word to spell. So what is cirrhosis? Cirrhosis is a chronic, hence the word chronic, irreversible fibrosis of the liver. So fibrosis is basically scarring. Has increased morbidity and mortality. Some of the complications include portal hypertension, hepatic encephalopathy, ascites, esophageal varices, spontaneous bacterial peritonitis, and hepatorenal syndrome. And we'll go over some of those and the treatments for them. So when you're looking at lab values, these are the ones that you'd see increase, which is basically all of them except for one. So you'll see your liver function tests, your AST, ALT, ALK-Phos, GGT, LDH, INR, and bilirubin increase. And you will see your albumin decrease. Signs and symptoms of liver failure: fatigue, weight loss, pruritus, so itchy, jaundice, yellowing of the skin, hepatomegaly, splenomegaly, which just means enlarged liver or enlarged spleen, encephalopathy, which is when your brain isn't working. We'll talk about more of that later. Or you could be asymptomatic. Causes: chronic alcohol consumption. It's one of the big ones. Chronic viral hepatitis, so if you have Hep A, Hep B, Hep C for a prolonged period of time, it can cause fibrosis of the liver. Metabolic liver diseases such as hemochromatosis or fatty liver, cholestatic liver disease, drugs, amiodarone and methotrexate are huge for cirrhosis causing. So there's some classification systems for cirrhosis, but I won't go into them. I'll just mention the names. There's the MELD score and then the Child-Pugh score. So some complications: portal hypertension, esophageal varices, hepatic encephalopathy, ascites, spontaneous bacterial peritonitis, which I will call SBP from now on. So what is portal hypertension? So basically, it's a pressure of blood that's backing up because the blood doesn't want to go into the hard liver, so it's a backup of blood, which causes esophageal varices. So there's enlarged veins in the esophagus since the blood flow to the liver is reduced. And there's smaller blood vessels in the esophagus that aren't meant to hold such big pools of blood, so they burst. This happens in about 50% of patients. And it's asymptomatic until they start to bleed, and they can be presenting with hematemesis or vomiting blood, black tarry stools, or lightheadedness. The treatment for esophageal varices is firstly keeping hemoglobin above 7. So if it's below 7, so say it's 6.2, you'd give a blood transfusion. And something that you'll start immediately with esophageal varices that are bleeding is ocrelizide. It's 50 microgram bolus and 50 micrograms per hour for about 2 to 5 days. You start it immediately. It's a somatostatin analog, which basically reduces portal hypertension by causing vasoconstriction. The next step is endoscopic variceal ligation, or EVL, or also known as banding. So basically they just place a rubber band around that blood vessel that's bleeding. There's some controversy over PPIs. It's not indicated, but it is used. May prevent ulceration at the band, so the band usually falls off in about 10 days. So it prevents ulceration, but like I said, not indicated, but sometimes used. Another thing that is used is ceftriaxone to prevent infection. It decreases infection, recurrent hemorrhage, and death. You give 1 gram IV Q24 hours. You continue it for a max of 74 days. Usually you discontinue it when the bleeding has resolved and vasoactive drugs have been discontinued. So when ocrelizide is off, then you take off the ceftriaxone. So prevention or prophylaxis for esophageal varices, non-selective beta blockers like propranolol, carvedilol, Nadolol. You want to get the heart rate around 55 to 60, so titrate to heart rate. Another prophylaxis would be banding or the TIPS procedure. The TIPS procedure basically decreases pressure of the hepatic vein. You can Google that if you want to know more. So the next complication is hepatic encephalopathy. So it's a brain dysfunction caused by liver insufficiency. There's a wide spectrum of neurological and psychiatric abnormalities. So you basically have altered mental status because your ammonia levels are so high. So the cause of hepatic encephalopathy is ammonia is produced by the breakdown of GGT. And the liver is supposed to convert the ammonia, detoxify the ammonia into urea, which is then secreted out via urine. But since the liver is not functioning, the ammonia builds up. It crosses the blood-brain barrier and causes neurotoxicity. And there's a way of classifying hepatic encephalopathy. It's grade 1 through 4, but we won't go into details of that. Treatment, lactulose, norfaximum. So lactulose for acute, it's 30 to 45 milliliters every 1 hour until you have a bowel movement, and then you titrate it up to 2 to 4 bowel movements a day. Rifaximin for acute encephalopathy is 400 milligrams TID, and then if you're going to use it for chronic encephalopathy prevention, then it'd be 550 twice daily. Other drugs that are used but not used often are neomycin and metronidazole. So metronidazole works, it kills the bacteria that produce ammonia in the gut, so just lowering the ammonia level, but it's not used that often. So the next complication is ascites. This one's a fun one to spell as well. So ascites is a fluid accumulation within the peritoneal space. Signs and symptoms: abdominal distension, abdominal pain, bloating, shortness of breath because you can't expand your lungs, and nausea. Causes: so serum ascites albumin gradient, portal hypertension drives fluid into the peritoneal space due to the increase in pressure. And albumin is a large protein that cannot cross this membrane. So first-line treatment is avoid alcohol. Sodium restriction, less than 2 grams a day. Avoiding NSAIDs because they can cause fluid retention. Diuretics, so there's a formula, spironolactone 100 milligrams with 40 milligrams of furosemide or Lasix. So it's in that increment, 140. So spironolactone 100, Lasix 40. And then a liver transplant assessment. Second line, if you keep getting recurrent ascites, you can do serial paracentesis. So it's basically when they stick a needle in and drain the fluid. So you do that like every week or every 2 weeks, just to stop the peritoneum, or to stop the ascites. Or a more invasive procedure is the TIPS or a shunt. So it's important to know if you do paracentesis, you need to see how much fluid that is drained. So if it's greater than 5 liters, you need to replace albumin because albumin can get trapped in there. So for every 1 liter of fluid you remove, for every liter of fluid you remove, you need to replace it with 6 to 8 grams of albumin. But that's only if you remove more than 5 liters. So next is SBP, or spontaneous bacterial peritonitis. It's an infection of the acidic fluid, so your ascites is infected. Most common bugs are E. coli, streptococcus, and Klebsiella. Signs and symptoms are fever, altered mental status, abdominal tenderness to palpation, nausea, and vomiting. So the antibiotic of choice is cefotaxime for 5 days. Prophylaxis, if they've had a prior SBP episode, you can do Cipro 500 every day, and then Bactrim 1 double-strength tablet. These are indefinitely. The last complication we'll talk about is coagulopathies. So you'll have an increased INR. Vitamin K, it's done but not supported. And then the next is thrombocytopenia, and you can do platelet transfusions for this. And that is cirrhosis. Have a nice day.